Thank you for coming to today's webinar. This is part of the webinar series from the Ioneer Foundation called Sight and Sound Bites. This bi-weekly webinar series highlights some of the research in the University of Pittsburgh School of Medicine. Today's topic is What's the Buzz? The Neuroscience and Treatment of Tinnitus. I'm Craig Smith. I'm part of the development team here at the Ioneer Foundation. The Ioneer Foundation supports research to advance care for vision, hearing, balance, voice, and cancers of the head and neck at the two world-renowned departments of otolaryngology and ophthalmology at the University of Pittsburgh. The funds that we provide from the Ioneer Foundation to support research are only possible thanks to philanthropic support. Some of that research you'll hear about today, so thank you to all who have supported, and thanks for your consideration in the future. I just want to go over a couple housekeeping rules before we get started. You can recognize that this is a Zoom platform. You might have used it before. We do have the chat function disabled today, so you will not be able to use the chat function. However, we do have the Q&A function. We will have a Q&A session following Dr. Tzounopoulos and Dr. Perez's presentation. So please feel free at any point during the presentation to submit your questions through the Q&A function, and we'll answer those at the end of the program. You can also send any questions to the email address provided in the invitation to me. We do ask that you avoid asking any personal, very specific medical questions during today's presentation, but again, feel free to email those questions along and we will try our best to provide an answer for you. You can also see that we do have a closed caption function on the program today, so please feel free to utilize that as well. Tomorrow we'll be sending everybody on today's webinar a survey. Any feedback is greatly appreciated as we use that to improve and shape our future webinar presentations. And we'll also be adding all of you to our email list for future webinars and research updates. I'd now like to introduce today's speakers. Dr. Thanos Tzounopoulos is a professor and vice chair of research in the Department of Otolaryngology and a UPMC endowed professor of auditory physiology. He's also the director of the Pittsburgh Hearing Research Center. Joining him is Dr. Perez. Dr. Perez just recently joined the department and is an assistant professor of neurology and otology here in the Department of Otolaryngology. Without further ado, I'd like to turn the presentation over to Dr. Perez.
All right, well, thanks so much. It's a privilege to be here. Like Craig said, I'm brand new to the department, but I completed my fellowship here under Dr. Hirsch and Dr. McCall in otology and neurotology, so ears and lateral skull base. And I'm excited to get to talk to everyone today kind of about our clinical approach to tinnitus and how we think about that from a practical perspective. And then I'm really floored to be joined by Dr. Tzounopoulos, who's a world expert in the research of tinnitus. And I'm excited to have him share with you the exciting things that are going on here. But let me give a little bit of overview of what we're going to talk about today. So I want to help break down what are the key features of tinnitus, basically explain the disease, explain how we think about it when we see somebody walking in our clinic door with this complaint, and then understand a little bit of what health burden that causes for the population and for our patients. We'll talk about what our current treatment options are and how we think about the different strategies for treating tinnitus, making it less intrusive in people's lives. And then I'll kind of turn over things to talk about research that's going on in this area. So broadly, there are two big categories when we think about tinnitus. One is called subjective tinnitus and one is called objective tinnitus. And the primary focus today will be on subjective tinnitus. And that's a sound that someone hears that doesn't have an external source. So it's a sound that they're hearing without some other underlying cause that we identify, as opposed to objective tinnitus is broadly described as a sound you're hearing that other people can hear. So it might be a clicking coming from the jaw joint. It could be blood vessel malformation around the ear. It could be a tumor compressing somewhere along the middle ear space, or a variety of things that have a little bit of a different pathway that we go down when we think about objective tinnitus. But much more common, much more frequent is subjective tinnitus, where we don't have an obvious underlying cause that others can hear. So we think about those as sounds that don't have an external source. And you'll often hear tinnitus described as ringing in the ears, but it might be better to really think of it almost like ringing in the brain. And we'll talk a little bit about how we think of it that way and why that's the case. It can present in so many different ways. It's really an individualized disease and experience for each patient. In terms of onset, it could come on suddenly. You wake up one morning and you have a new ringing in the ear. Or it could be gradual, slowly over time you notice, hey, when I'm in a quiet environment, I'm hearing this new sound I didn't remember hearing before, ringing and buzzing. And the quality can really vary quite broadly. It's common for people to describe a ringing sound, a tone that's often high-pitched, can be a buzzing, a hissing, a clicking, a matching the heartbeat, which takes us down a little bit of a different pathway, and we'll talk a little bit about that. But so many different ways that people will describe it and that they're hearing it. In terms of pattern, it can be constant with you all the time. It can fluctuate. Some things make it better, some things make it worse. Within that realm, it's common for a quieter environment to be a place where you're more likely to hear it. And then that in terms of loudness, some people can have extremely loud tinnitus that they can hear all the time in all sorts of environments. For others, it's more in the background. And so you have to get in a really quiet environment, especially when you're trying to go to sleep at night, which can drive people crazy. But about half of people will experience that at what we would quantify as about a 5 decibel level. If you get them to match the sound above the regular threshold hearing, 5 decibels is a common amount. So it can be drowned out with some background noise, but in quiet environments, very audible. And then in terms of the site, it can be located just to one ear. It can be both ears. Some people describe as hearing it in the head. It doesn't really localize, but they hear it somewhere in the head. Those are some of the qualities we think about. And then what causes tinnitus? There's some things that we know and a lot that we don't know. So for the majority of people, an inciting event in starting off tinnitus is some kind of hearing loss. That could be really from any sort of cause. The most common causes of hearing loss that we see are hearing loss related to aging, age-related hearing loss that's the result of noise or sound trauma that causes some injury to the ear. But there are a myriad of other causes, and those involve both nerve hearing loss that affects the inner ear and other causes that affect the transmission of sound through the normal mechanism, the normal physics of hearing through the ear canal, eardrum, little bones of hearing. So something as simple as wax in the ear that's blocking off hearing could give you a new tinnitus. You could have a hole in the eardrum. You could have some stiffness of the middle bones of hearing. So really anything that decreases hearing could be an inciting factor for tinnitus. But then what happens downstream from that is really important. And so there are definitely changes that happen in the brain and the central auditory processing that happens with that sound signal after it goes from the ear. So a common way to think about this is the brain is used to receiving lots of input from both ears all the time. And so you take away some of that input and suddenly the brain is craving that lost signal, turns up its appreciation and ability to detect that and can begin to create its own sound. So that's why we kind of think of the brain as filling in the gap and basically creating some of that sound that you could think of as ringing in the head as it misses that hearing loss. We also do know that there are many other circuits in the brain that play into tinnitus and especially into the bothersomeness of it. A lot of things we don't know about what causes tinnitus. One example is that even though the vast majority of people who have tinnitus, we believe have some level of hearing loss, there's far more people who have hearing loss and don't experience tinnitus, which we don't have a good explanation for. A really key feature that I think is a focus of research and how we can really advance to help patients is understanding what makes tinnitus bothersome to one person and really not an issue for someone else who might be experiencing the exact same quality, the same loudness of that tinnitus. For one person, it can fade into the background and become part of their new normal. For another person, it can really alter their life in meaningful ways and really be quite bothersome. So Understanding what makes it bothersome and what other brain circuitry is feeding into that and how that might be altered, I think is a really pivotal concept in advancing our understanding and treatment of tinnitus. And a good way to think of that is experiencing versus suffering from tinnitus. So you may have this pitch present or the sound present in your ear and know that it's there. If you listen to it, you can hear it, but that's different from really suffering from it. How do we diagnose this? So, tinnitus should be evaluated by an otolaryngologist, and that involves taking a history from the patient and a physical examination. When we think about the history, we want to know, when did this start? Has it been constant, or is it fluctuating? How long has it been going on? How severe is it? How is the loudness? How bothersome is it to you? Are there any factors that seem to make it worse? Do you find that, especially at night in a quiet environment, is that really the problem that's bothering you? Are you drinking 3 cups of coffee a day and noticing that day it turns up the volume? Or are there things that can make it better, such as background noise, music, being in a little bit of a louder environment? And then we always want to know from the patient, did you perceive a change in hearing? As we often suspect that to be a starting point, we want to know if the patient noticed something related to their hearing change. Dizziness is another important symptom that we want to know about that can kind of shape how we think about an underlying disease that could cause this. It's important to know any new medication changes. There are a number of medications that can affect tinnitus, and so having a thorough history in that regard is important. And then a very careful examination of the ears with a microscope to look at the ear canal, the eardrum, help us assess the middle ear. And then, especially if somebody describes a tinnitus that matches their heartbeat, a pulsatile tinnitus, we'll often listen around the area to see if we can pick up on some of those sounds as well that can help point us towards the diagnosis. This is a nice picture of an eardrum. This is a right eardrum, so you're looking through the ear canal and you see a really healthy eardrum that's clear like cellophane. You see one of the attachments of the first bones of hearing. And you can see through that space to what we call the middle ear behind the eardrum to see one of the second bones of hearing. And it's nicely filled with air, no fluid, no infection, no tumors, nothing that would give us a reason to have hearing loss in this ear. And then you can compare that to somebody who walked in hearing the heartbeat in their ears, and you take a look and you see something that's abnormal here. Not a common, but a tumor that we'll see from time to time growing in the middle ear that is filled with blood vessels, pulsing away, and is a common cause of pulsatile tinnitus, or that objective tinnitus when that's present. Another really essential part of our workup for patients is a hearing test, also called an audiogram, and that's performed by our audiologists here who work in our clinic on the 3rd floor but have their entire department 1 floor above us on the 4th floor at the Eye and Ear Institute. And we'll measure the hearing in a sound booth to detect hearing thresholds and also hearing understanding. I have some examples here. This is probably the most common audiogram that we would see for somebody who presents with tinnitus, and that's a normal hearing test by what we measure here. This shows low pitches on the left side, high pitches are on the right side. So birds chirping up here, cars rumbling down here. Up at the top of the graph is quiet sounds at 0 decibels hearing level that are normalized here. And then as you go further down the graph, those are louder decibels that we had to play for the person to hear that. We show the right ear in red, the left ear in blue, and this looks just how you want it, up in this gray box of normal hearing with both ears being the same. Now, here's an example of somebody who definitely has a difference between the hearing loss. This person did come in with a new tinnitus in the left ear, and we were able to measure a significant hearing loss in that left ear compared to pretty normal hearing on the right up in this gray box. And you definitely see a dip, especially in some of these middle frequencies that were underlying this tinnitus. So that's a really essential step in our workup of tinnitus, is to know what the hearing is that can help guide treatment and our evaluation of any other workup that needs to happen. So most of the time, a history, a physical exam, and a hearing test are sufficient to help diagnose people with tinnitus and give treatment recommendations. But occasionally, there's some other factors that will point us down a different direction. And so Pulsatile tinnitus, or tinnitus that matches the heartbeat, does warrant a little further workup with some other imaging to look for abnormalities of blood vessels, a possible underlying tumor. Still most common to find nothing when we do that workup, which provides reassurance, but it's something that you don't want to miss when that's the case. And then when we see tinnitus that really is very much in one ear or unilateral, that also usually will prompt us to look a little bit closer and often obtain more imaging, such as an MRI, to make sure that there's nothing else underlying that, like a tumor, for example, that could grow along the hearing nerve. That can be present even when the hearing test shows the hearing is normal between the two ears. More commonly, we would see hearing loss in one ear when there's only tinnitus in one ear. And what is the health burden that we're experiencing? It's massive from tinnitus. A lot of people experience tinnitus, and the minority of those are really suffering from tinnitus. So about 50 million Americans are estimated to have what we call chronic tinnitus lasting more than 6 months. And of those, about 12 million have tinnitus that's severe enough to interfere with their daily activities. So it's actually disabling to them. There are some known risk factors, including hearing loss, increasing age. So the seventh decade is where we see the peak of tinnitus experience, history of exposure to noise, and also male gender as a risk factor. And then we know that this problem is common, but will only increase in how common it is with our growing population aging. It's also important to know that there's a high association between anxiety, depression, and sleep problems that occur with tinnitus. And this really becomes problematic because these diseases can definitely build on one another. And we think of about a vicious cycle where the tinnitus didn't necessarily cause the anxiety, but the tinnitus can make somebody's anxiety worse. And the same is true in reverse. The anxiety can really enhance the suffering that comes from tinnitus. So they are diseases that make each other worse and that we have to approach from a multi-pronged approach for sure. And then thinking about treatment, there right now is no cure for tinnitus. And that can sound disheartening to some people, but I think it's important to think about the treatment options available to try to mitigate how this is affecting people's lives. Right now, there are no FDA-approved medications. There have been a number of medications studied, and there's active research in medications that may help. But right now, it's important for patients to know that it's not recommended currently that we prescribe medications to treat tinnitus. One of the mainstays is really counseling and education about tinnitus. So explaining what we know about it, what we think is underlying it, and basically being able to rule out the big, bad, scary causes that we want to make sure are not present and rule out. We talked about some of the comorbidities that can occur with tinnitus, and treatment of those is essential to really helping patients improve their experience with this. So it's very common for us to have an involvement of mental health providers, therapists, psychiatrists, to help get some of the other diseases that we can get under better control to mitigate the effects of tinnitus. Hearing rehabilitation is a big part of our treatment for tinnitus. And in patients who have hearing loss, hearing aids can be effective in reducing the experience and the bothersomeness of tinnitus. A cochlear implant is something that is considered when the hearing loss is severe. And right now, it's not something that we recommend as a treatment for tinnitus primarily, but there is evidence that shows many people who have a cochlear implant and have improvement in their hearing actually can have reduction in their tinnitus. Another mainstay of treatment is something that we call masking. So using sounds to help decrease the experience of tinnitus. That can be something like white noise played especially at nighttime. There are various apps that will provide background noises, ambient noises that can help cover up some of those sounds and provide a little bit of a distraction from the tinnitus. There's also masking that can happen with hearing aids. So in addition to hearing aids just improving the hearing and that alone helping with tinnitus, there are options to actually pump in a little bit of sound that's a masking sound that's played throughout the day to help with tinnitus. Behavioral therapy is another approach we use for the treatment of tinnitus. And really the mainstay here at UPMC is something called the tinnitus retraining therapy that's run by Dr. Lori Zaitelli in our audiology department. That's a program that focuses on habituation of the experience of tinnitus. So it involves hearing aids with background sound that are played throughout the day, and essentially being able to get your mind used to hearing that sound so that it's no longer a prominent feature in your experience throughout the day. There are also options for things like biofeedback that involve basically being able to detect some of the signals your own body is sending you to regulate how you're experiencing tinnitus. Cognitive behavioral therapy is another option that has been shown to be helpful for patients with tinnitus. And that is helping to basically reprocess how you're responding to that experience of tinnitus and take what can be a negative connotation and negative reaction to that sound and remove that negativity into something that is less bothersome. So those are kind of a brief overview of how we think about tinnitus and what our current treatment options are, but there's a lot of research to be done to improve our understanding. And so it's important to know that this is a heterogeneous disease, and there are probably lots of things underlying it that we call tinnitus, and helping to understand the different forms of that disease in different categories is helpful for developing a more individualized treatment plan. Obviously, if you could find a pill that you could give to people that would help with tinnitus, that would be a huge advancement. So there's definitely research being done in pharmacologic therapies for tinnitus. Other areas include neurostimulation, such as simulation through the scalp, that are pretty experimental at this time and not something we're prescribing, but an active area of research. So I'm going to turn it over to really one of the world's experts in tinnitus to talk about what research is ongoing right now.
I think Dr. Perez covered a lot of ground here with tinnitus in terms of treatment and causes and etiology. And what I would like to talk to you a little bit more in a little bit more detail in the next 5-10 minutes, what are the different mechanisms, at least from a neuroscience point of view, that can lead to tinnitus. So I'm going to be brief, as I said, it's going to be about a 10-minute talk, but everything I want to tell you is in a review article that we just published with my student, Amanda Henton, with the same title, and basically that describes in more detail what I'm going to tell you today. So what is tinnitus? Mechanistically, I don't think we fully know. We don't know what are the necessary and sufficient changes that need to occur to create tinnitus. But we have made a lot of progress, and I would like to talk to you a little bit more about that. So in terms of a mechanistic part definition, the closest I think that I can get is that tinnitus is in most cases initiated by acquired hearing loss and maintained only when this loss is coupled with distinct neuronal changes in auditory and extra-auditory brain networks. I know it sounds vague, but hopefully that will become a little bit more specific. Which are these auditory or extra-auditory networks that are involved with tinnitus? So I know this is a complicated figure, but for now, please focus only on the purple things, because the purple color shows the different parts of the brain that through research have been shown to be associated with tinnitus. So, okay, the first part, as Dr. Perez says, and as I told you, there is some sort of peripheral or hearing loss. In most cases, not in all cases, and maybe I can explain to you why you could have tinnitus potentially without peripheral hearing loss. So there is some loss in some peripheral hearing loss. Then, as soon as then the auditory information from the cochlea gets into the brain, it goes to the cochlear nucleus, and specifically in the dorsal cochlear nucleus. And people have shown, including our team, that as early as in the brain, it's echoes of what Dr. Perez said, that because there is a reduced nerve activity from the cochlea to the brain is trying to increase this gain, right? It's trying to fill the gap or increasing the intensity of whatever it receives. And then people have shown, as I said, including our lab, there is a hyperactivity, a more robust activity of neurons in this part of the brain. Then, oops, I didn't mean to do that. Then that continues to the inferior colliculus, which is in the midbrain. This is the next step of the auditory after the brainstem. And here is also, people have seen some hyperactivity, and also they've seen changes in temporal coding deficit. I will explain what that is. For neuron, when we talk about hyperactivity, it means that neurons fire more, right? They're more active. But sometimes the pattern of activity of a neuron can be extremely important for how the brain operates. And there are changes in the temporal pattern of the activity of these neurons. Then the next step is the thalamus, or the auditory thalamus, the medial genital body, which is shown here. And there is also changes, temporal and hyperactivity changes in the thalamus. And then the information goes to the auditory cortex, and people have shown in the auditory cortex there is more activity, the different parts of cortex and through the whole auditory system actually, they encode sounds of different frequencies at different part of the brain. So this tonotopic map is has changed after tinnitus. There is increased gain. Imagine the knob that Dr. Perez also talked, there's more intensity to whatever gets into the brain. There is more synchrony in neurons. And these are the neural correlates, if you will, of changes associated with tinnitus for the auditory system. But then there are two more other networks, big networks that have been involved with tinnitus. One network is shown here on the right? This is the frontostriatal network. So the idea there's this theory of tinnitus that there is reduced frontostriatal gating. What does that mean? This theory posits that the nucleus accumbens, which is shown here, and the prefrontal cortex are central parts of a network that evaluates the relevance and affective value of internally generated percepts. Okay, to understand that, to make that a little bit simpler, our brain is not that it does nothing and then a sound comes and the brain starts working, right? The brain is constantly working. There are internally generated sounds, and the brain, as Dr. Perez says, is trying to always anticipate the external environment so that it's ready to react to it. So, you can imagine a sound, right? And almost hear a sound without an external sound when you want. That's not tinnitus because, you're thinking of a nice song or a nice. So there is that system, which is shown here, that basically gates what makes this internally generated percepts, how do they reach our consciousness? So basically the way it happens is that this area here, the prefrontal cortex, connects to the TRN, which inhibits the thalamus, right? So it can inhibit the auditory information right here. So if there are deficits in this gating mechanism, you can imagine that now it's not voluntary what you want to hear in your imagination, right? Or what you want to evoke, but when the system is off, this information can become, you can perceive it when you don't want it. So that has been also involved with tinnitus, and people have shown that there is reduced gray matter in individuals with tinnitus that leads to less inhibition here. Now, the other networks that are involved with tinnitus is the parahippocampus. These are more the mnemonic networks. Again, it goes back to the idea that the brain is trying to predict the future and it's trying to fill in the information that is looking for, if you will. So sometimes this information can come from the hippocampus, from the parts of the brain that have to do with memory. So these parahippocampal memory networks are thought to contribute to the maintenance of tinnitus by encoding the memory of the tinnitus percept and subsequently reinforcing involuntary auditory memory and perception. And people have shown in individuals with tinnitus, people have seen increased activity in this area in the parahippocampus. But I would like to tell you that for the mnemonic networks and for the frontostriatal networks, research in terms of the mechanistic underpinnings of the involvement of these networks in tinnitus are not very well understood, right? There are very few studies that have initiated them. They do make sense, but we don't have cellular and molecular mechanisms behind it. However, for changes that are in the auditory system, there has been a better mechanistic understanding. And frankly, that also has led to neuroscience-based attempts for treatment or for cure. So for the peripheral loss, which is associated with the hearing loss associated with tinnitus, there are already companies that try NMDA receptor antagonists and other molecules that are trying basically to rewire the cochlea to the brain. Basically, they're trying to correct hearing loss, right? Is that going to correct tinnitus? It's we can discuss that later, but certainly would be a huge advancement to solve the sensory problem. Then regarding here, once it goes to the cochlear nucleus and this hyperactivity, people have shown that this can be due to decreased inhibition, GABAergic inhibition. This is GABAergic and glycinergic inhibition. These are inhibitory neurotransmitters that are involved in this area, in the dorsal cochlear nucleus. And also work from our lab has shown that there is a decreased potassium channel activity. Potassium channels are proteins which are breaks of activity in the activity of the neurons. And then when these breaks don't work, then you can have pathological activity of the nucleus. And at least in animal models, we've been able to correct this hyperactivity and the tinnitus by activating this channel with an activator that I'm going to talk to you about that later. And then there is also hyperactivity in the inferior colliculus, and that was also linked to decreased activity of a potassium channel. And actually there was a clinical trial for using KB 3.1 activator to correct tinnitus. It failed on phase 3. Then also there are these receptors here, they're called metabotropic glutamate receptors, which are participating in this hyperactivity in the inferior colliculus. This is from animal model work. And I know that people are pairing agonist activators of these metabotropic glutamate receptors, and this is at the preclinical stage to try to help this condition. So although there is not full understanding yet, or a treatment yet, already we know a lot from a neuroscience point of view, and already there are efforts to try to solve this problem. So I want to show you some of these are the preclinical and clinical tinnitus drug development that happens right now. As I do, these NMDA receptors from Autonomy and Oris Medical, they're trying to correct hearing loss. So is GPX from Sound Pharmaceuticals. And then Otifony tried the 3.1, which failed in phase 2. And we're getting close to try these potassium channel activators. And I know another group is close to start trying for this group 2 mGluRs, and then also the calcium channels. So there are efforts, but unfortunately, what I want to say here is that what we do not know yet, we do not know the exact electrical patterns of activity that are necessary and sufficient for the generation and the maintenance of tinnitus. They line these networks, but the precise geometry and the underlying mechanisms are not fully clear yet, right? And that has been a problem. There is, as Dr. Perez said, there is much more neuroscience work that needs to get done. So we figure out what is the exact necessary and sufficient changes that will lead to tinnitus. So for the final few more minutes, I would like to go a little bit closer to what we have done here with in the last 10 years, trying to understand the mechanism of things and hopefully come with a solution. And also that's an opportunity for me to help again to thank again the Ioneer Foundation for all the support during all these years. So in 2009, we developed an animal model to measure tinnitus in mice. Then we determined that this part in the dorsal cochlear nucleus that is very important, is necessary actually for the initiation and the beginning of tinnitus. Then we identified in 2013, we identified this potassium channel that does not work properly in these neurons and leads to this hyperactivity in the brain. Then in 2015, we started working with Dr. Peter with He's a great medicinal chemist here, also working at University of Pittsburgh. And he modified a pre-existing drug to make it activate the potassium channel that we're interested. And by using the pre-existing drug and also the new molecules that Dr. Peter Wick generated, we're able to correct tinnitus in mice. Then we kept mainly Peter Wick, Dr. Wick, he kept improving, if you will, the structure of the potassium channel activator so I can make it more specific and more potent. And preclinical testing to determine safety for human trials started about a couple of years ago. And our primary molecule has been RL81. In the last year, we found some potential toxic problems with RL81, but that's not a huge problem yet because now we know what the problems are. And Dr. Wick has more molecules which are expected to solve this problem, this toxicity problem. So we continue with the preclinical development, and we hope that soon we're going to have clinical trials with this molecule. So I would like to finish it here and hopefully hear some questions. Thank you.
Thank you, Dr. Tzounopoulos and Dr. Perez, for a great presentation. We definitely have several questions rolling in already. To our audience, please feel free to submit your questions now through the Q&A function at the bottom of your screen. We'll get to as many of these as we can over the next 20 minutes or so, but we'll go ahead and get started right away. So the first question is, if a person has considerable earwax, should they consider scheduling regular cleaning with their PCP to prevent tinnitus?
That's a great question because earwax is one of our favorite causes of tinnitus because we can fix that easily. That being said, for most people, we call the ears self-cleaning. Even though the ears produce wax to varying degrees, wax is actually healthy for the ears. It helps with waterproofing. It has some antibacterial properties. So you do want wax in your ear canals. Obviously, when it's fully blocking off the ear canal, that causes a problem. And the patients we see who especially will have issues with that are hearing aid users. So if you're somebody who always has something going in your ear canal, that can predispose you a little bit more to wax buildup. So we certainly have people who come to see us in the clinic at regular intervals for cleaning of earwax. But the vast majority of people actually don't ever need ear cleanings. But if it's something you suspect, give us a call, and we're always happy to do that. That's something that's also done by primary care providers, but we're always happy to provide that in the ear clinic.
Do people with low pain thresholds have a worse time dealing with tinnitus?
I would say putting somebody in a category of having a low pain threshold, they certainly could be somebody who is more sensitive to changes in their environment and to stimuli that could correlate with bothersomeness of tinnitus. So it would be difficult to say that every person who has a low pain threshold is more likely to be bothered by tinnitus. But I think that if you were to look at those two groups of people, there would be considerable overlap.
Can you address Meniere's disease and its effect on tinnitus?
Yes, so Meniere's disease is a very specific diagnosis that we do see a fair amount in our clinic. And that is a disease that classically will present with these episodes of vertigo. The room is spinning around you, your hearing goes down, you have what's classically described as a roaring tinnitus, and you might feel like the ear is stuffed full of cotton. So that's the really classic presentation, and comes in episodes that would last typically hours before resolving, although you can definitely have residual effects as you're kind of recovering from that episode. That's also a disease that is really variable in its presentation. So some people are getting an episode once a year and other people are getting multiple episodes a week like that. But tinnitus is a salient feature in that disease. It also is a disease that tends to over time damage the hearing. And so that damaged hearing does predispose you to residual tinnitus left behind, even when you're not having one of those acute episodes or attacks, as we call them, that can have all of those symptoms be a lot worse. So that's somebody who they usually come in complaining of the vertigo, and you have to push them a little bit to talk about the other symptoms that are affecting the ear as well. But there's also kind of a spectrum within that disease where some people can have attacks that don't have so much dizziness or a vertigo, but can have hearing fluctuations, tinnitus that gets much worse for periods of time.
His next question is, what experience have you seen with tinnitus and hyperacusis? I guess maybe the connection between the two.
Hyperacusis is a term we use to describe sounds that normally you wouldn't think should be bothersome to somebody can almost hurt, be painful to the ear. So it's a sensitivity to sound, an increased sensitivity to sound. And they definitely tend to correlate with each other. We see them together frequently, partly because we think that there's a similar process underlying both. So we think that hearing decrease underlies or initiates both of those diseases. With tinnitus, we think of that hearing loss leading to the brain kind of wanting to turn up the volume, fill in the gap. With hyperacusis, what we believe and think about that is damage to some of the cells of hearing cause some of the other cells that are still functioning around that to turn up the volume a little bit. And so you kind of narrow the range in between what you can actually hear and understand. So we might have to turn up the TV volume to 50 to hear it well, but then you go up to 55 and suddenly it's painful. Whereas somebody who has normal hearing could have a much broader range of hearing sounds that are understandable and from low to higher volumes and not be so bothered by them. But it's really that narrowing of the range that is a salient feature of hyperacusis. And we do see closely in association with tinnitus because typically both of those have some level of hearing loss underlying them.
Have you ever investigated TDCS as a potential tinnitus treatment? I'm hoping you guys know what that is because I don't.
TDCS.
No, that is not.
Is that some kind of related to transcranial stimulation? I don't know what the D stands for.
We can circle back privately with that individual after the fact. So next question is, do you use any objective diagnostic method to diagnose tinnitus?
Oh, that's a great question because people would love to have an objective measure. And that it's definitely something that's been researched in terms of, can you use something like a functional MRI to identify different patterns in brain circuitry that underlie tinnitus, or even some external testing, kind of like an EEG for your scalp to identify different patterns or different auditory processing that would objectively say, yes, this person has tinnitus. But right now, that is not something that's been proven, and it's a tough issue because when somebody tells you have tinnitus, we don't have a way to measure that objectively. So no, right now there's not an objective measure, but there are a lot of people who would love to have that for sure.
Does tinnitus affect the music we hear, or the other way around?
Definitely had patients tell me that their tinnitus affects how they hear music, and it can be such a prominent tone that is present even when they're listening to music at loud levels. It's also true that there are some therapies that involve listening to music to try to change the perception of tinnitus. So I think that it's a two-way street, and they definitely can affect each other.
Does hearing damage resulting in tinnitus result in decreased resilience to sound and greater risk of further damage from environmental noise?
That's an interesting question. I think, in general, if you have hearing loss and you are, not able to hear sounds as loudly, in some ways that can be somewhat protective from additional sound causing additional damage. But the flip side of that is that, you know, your peripheral auditory system, your ear has already suffered some level of damage. And so you might be hanging on by a thread and might not have as many options to fill in the gaps. So I think that both are true, that you actually, in some ways, could be protected from some louder sounds if you just cannot perceive them. But I think your residual ability to hear that sound does make you a little bit higher risk for additional hearing loss.
This might be a question for Dr. Tzounopoulos. Have you studied the underlying mechanism for residual inhibition effect?
I have not, but there are groups that they do, especially there are groups that, when I mentioned that, when I showed this map of things in the inferior colliculus, and the M-GLUR receptors might be involved in that. But I don't, but people have and keep doing that.
I think the next question is one that everybody's interested in. However, I know that we probably can't really give an exact answer, but maybe Dr. Tzounopoulos, you can kind of give your thoughts, is how long until we might see a clinical trial?
Clinical trial from the stuff that we're doing here? That's what you're talking about, right? You know, we had a lead candidate, right? Which was, and still is our leading one. There were some toxicity issues, but now we know what they are. And we have more compounds that have been designed to address these problems. It's hard to put an exact time, right? Because it's a science, you know, it's a trial and error thing, right? So we keep testing the compounds. I would like to believe again that in a year or two we should be able to have clinical trials, but beyond the time, which is again, take that with a grain of salt, because frankly, I do not know. What I can say is that we are committed to continue this line of development, and the study keeps going. So we're going to keep going until we figure it out, right? To me, that's what I feel more comfortable saying.
The next question is the gain that's mentioned in Dr. Tzounopoulos' diagram experienced by the patient as hyperacusis?
As Dr. Perez said, hyperacusis and tinnitus are presenting together very frequently, right? I forget the percentage, but so yeah, it could be very likely that this change in gain that we see mechanistically could be underlying hyperacusis and the symptoms of hyperacusis.
Has there been any research done, or is there being any research done now connecting tinnitus and the COVID vaccine?
I do not know. I don't know, Dr. Perez. I do not know.
There's one small report I've seen that basically, so it actually wasn't tinnitus, but it was sudden hearing loss, to try to correlate what's been self-reported in a database. And they didn't identify an increase that's happened after the COVID vaccine, but that's a question we get a lot. A lot of people will experience sudden onset of tinnitus or sudden onset of hearing loss. Maybe a lot is an aggressive term to use, but you know, something that people have come in with. And you know, from our standpoint, it hasn't changed significantly from before the vaccine. So we haven't seen on just kind of our day-to-day clinical basis a difference, but so far I haven't seen a good wide study that's looked at that.
So I'm gonna have to apologize. Dr. Perez or Dr. Tzounopoulos, can either of you see the questions right now? I'm having a little technical difficulty on my end. I'm not sure if it's on.
I can't see the questions yet.
Would you mind go ahead and proceeding while I try to work through my technical issue?
Sure. Looks like there's a question about being placed on a notification list when trials begin for tinnitus and the best way to get plugged into that.
Yes, when we start, of course, it's going to be listed at clinicaltrials.gov. We're going to do that. But also, if you go to our website at the PHRC, Pittsburgh Hearing Research Center, I will definitely announce that when the trials start.
And then there's another question that asks, with a history of cholesteatoma, bone degradation, and ruptured eardrum, would future drug therapies be likely to have any potential effect on tinnitus? So that's a question that's talking about one of those other causes of hearing loss where, perhaps the inner ear is working okay, but the transmission of sound to the inner ear is disrupted. And I would say broadly, yes, if there's a medication that could help with tinnitus in general, we think that would be acting somewhere kind of upstream to help affect how the brain is adjusting to those changes. So I would say even causes of hearing loss that aren't nerve damage could be improved with ideally the therapies that we're trying to develop. It looks like there's a question, can head/neck trauma or occipital neuralgia cause tinnitus? And the answer is certainly yes. We've kind of talked about the various circuitry that is involved in affecting tinnitus. Some things that are definitely known are nerves that affect sensation in the head and the neck, can definitely affect perception of tinnitus and alter tinnitus. We have patients who come in and say, I can twist my neck and change the tinnitus, or I can move my jaw. There's some people actually studying, is there a way that you could use that sensory input of one of the nerves to the face, the trigeminal nerve, to help change how the brain is processing its response to tinnitus. So there certainly is a lot of interconnectedness that's still being dissected to understand that. And the other thing to mention is we do see head trauma as a cause of hearing loss. So sometimes something we'll call cochlear concussion, where you actually had some nerve hearing loss from the actual trauma, like a car accident. And then it looks like, do you think the potential solutions to tinnitus and hyperacusis are the same or different?
It goes back to what Dr. Perez said. It's such a heterogeneous disorder. I think for some of the population that have tinnitus due to gain and hyperacusis due to changes in gain, it could be the case, right? So I guess I don't think in every case it's going to be the truth, right? I don't know, what do you think?
I agree completely. There are probably some people who it's a very similar mechanism underlying both, and if you could fix that, you would fix both. But I'm sure there are people who you could maybe fix one and not the other. There's some pattern that is maladaptive for one and not necessarily having an impact on the other.
And that, to make a comment here, is that for the future of research and clinical care, I assume the idea of, and Dr. Perez mentioned that during his presentation, categorizing tinnitus to different subtypes, right? And especially through a neuroscience-based categorization could really help research, treatment, and cure, right? If we can, and I think this is a big effort right now. Fortunately or unfortunately, perception is an emergent property. There's so many networks that come together to bring it, and tinnitus is a percept, right? It's an internal percept. So you can understand that already I put several networks there, right? Obviously, the auditory network, the hippocampal network, the frontostriatal network. It might be that different people have deficits at different networks, right? And still come with tinnitus. The question is, can we ever fully understand? No, we're going to fully understand that. And then once we understand that, we'll be able, depending on the individual with tinnitus, right, to disengage, let's say, the frontostriatal network, or the parahippocampal network, or the gain. So that's the vision, right? And I think this is where the solution is going to be. Personally, I don't expect, but it would not shock me that just one thing is going to solve tinnitus for everybody. And what do you think, Phil? You see more patients? Is it?
Yeah, I completely agree. I mean, there are some people who, the one thing you fix is underlying anxiety. They get that under control and suddenly their tinnitus is not an issue. But that's only a small fraction of people. And I think it's so true that there have got to be a lot of underlying causes and a lot of different true diseases that will get classified into presenting as this endpoint, this symptom of tinnitus. Other questions? Any theories on why some people with acquired hearing loss develop tinnitus while others do not? That's a big question. And the answer is I don't know, but I think it goes back to a lot of what Dr. Tzounopoulos was talking about, these other patterns that happen upstream in the processing that information and how that circuitry becomes normal or abnormal and how we pay attention to what's going on there. So I think that it has to go back to less of the ear, less of the damage that happens to the ear and more to the processing that happens in the brain and the different circuits that play into that.
Yeah, I agree.
Another question is, are there links between migraine and tinnitus? And yes, we definitely see that a fair amount, that people, I would say fluctuations in tinnitus, they will notice worsening with their migraine. And I think broadly you could put them in a category of, having multiple inputs and multiple circuits that affect the variability and severity and bothersomeness. But we do see people who have migraine that's not well controlled seem to make their tinnitus worse, and better control can improve their bothersomeness of tinnitus.
I think we might have time for one or two more questions, depending on what they are. Dr. Perez, if you could continue to go ahead and ask whatever question.
Sure, yeah. Here's a question that says, you mentioned the need for more neurological research. Are there any groups currently researching the mechanisms of frontal striatal gating and the parahippocampal, I guess, input and how they contribute to tinnitus?
So I know that, the frontostriatal gating theory came from the Rouse-Shecker lab. And I think they're still doing some research there. This is mostly was from human related research. So which is a little bit harder to get at the cellular and molecular level, right? But I think, and I hope they're continuing on that. We're interested also in some aspects of how the synapses change in this network and see what is going on there. Then regarding the parahippocampal aspect, again, I think that was a theory that mainly came from the Reader group. Again, this is human related research, and they found changes in parahippocampal networks, and they linked that to tinnitus. I'm not sure who else is doing that, but I hope they do. In the article that I told you, the review that I told you that we wrote with my student Amanda Fenton, I go in great detail there how the theories came and what needs to get done. But to give also a brief answer of the future, more research needs to get done for these two theories in terms of the cellular and the molecular mechanisms in order to further advance treatment and understanding of the disorder and the brain.
I think we'll go ahead and end there. And kind of a closing off point, as Dr. Tzounopoulos just shared, that there is more research that needs to be done here. And obviously this research is possible, as we mentioned earlier, from the support for everybody who has supported the Eye and Ear Foundation. I think Dr. Tzounopoulos' one picture that he showed earlier kind of really reinforces that idea. He showed the graph of the support that he's gotten both from the Eye and Ear Foundation and from other sources over the years, and the difference it has made in the amount of research that he's been able to do. So we're very appreciative of the support that we receive. And if anybody is interested in supporting this type of research, you can do so by visiting our website. It's just www.eyeandear.org. I apologize again for the slight technical difficulty. And I know we couldn't get to everybody's question. However, we are going to save the questions that we didn't get to, and we're going to try to reach back out to everybody individually. We have your email addresses, and we'll try to get you the answers to your questions that you have. Please join us again for our next webinar series on Wednesday, October 20th. We'll be joined by Dr. Ellen Butts and Dr. Scott Drexler for a presentation on contact lens safety. Thank you again for joining us today, and thank you, Dr. Tzounopoulos and Dr. Perez, for a wonderful presentation. And we hope everybody enjoys the rest of your afternoon. Take care.
Thank you.
Thank you.